So next talk will be Dr. by Adit Gupta. He is in private practice. He is in cornea and surface consultant in Mumbai Eye Plastic Surgery, and he will be, deliver the talk evaluation of the lacrimal system. Over to Dr. Adit.
Very good morning to everyone. Now, before I begin my talk, obviously as postgraduate students, all of you perform lacrimal irrigation, right? Yes. So with this talk, I'm going to explain how evaluation of the lacrimal system is more than what we usually do in our postgraduate practice. But before we begin, we need to know or clarify basic terminologies, that is lacrimation, which could be hyperlacrimation, which causes watering from the eyes, epiphora, which means basically overflow of tears, which could be anatomic or functional, and then how lacrimal system is divided into two parts, that is the secretory system and the excretory system. So now I'm going to take you through a lot of pictures to make you understand better how this system works. A lot of it has been covered by my colleagues about the ocular surface, so I'm going to focus more on punctal pathologies and lacrimal system, excretory system pathologies. But the lacrimal system basically is a very big system. It encompasses right from the lacrimal gland, the whole of the ocular surface, that is the tear film meniscus, the conjunctiva, the eyelids, the muscle, the orbicularis muscle, and then going down to the punctum, canaliculi, and the lacrimal sac. Now, the most important part of this system for it to maintain a balance between secretion and excretion is the orbicularis muscle. And as we can see here, the orbicularis muscle basically converges onto the medial canthal tendon, goes ahead and behind it, and forms the muscle of Riolan, which basically helps squeeze the tears from the canaliculi into the lacrimal sac. So this happens with the blink reflex. So now if we were to describe the lacrimal system and make it into three parts, one is the secretory, the number 1 is labeled against it, it's the lacrimal gland. You can see this is the lacrimal gland with all the ductules entering into the superior temporal fornix. The accessory glands of Krauss and Wolfring, which lie along the phonacial conjunctiva and at the apex of the tarsus. Now, the third part is the second part is the ocular surface or the tear film, which is spread all over the eye, and the third part is the punctum, the canaliculi, and the NLD. So depending on where the pathology lies, if it is in the secretory part, we classify it as hyperlacrimation, which could be reflex in response to some stimuli, or sensory, which is because of a CNS pathology or because of aberrant regeneration of the nerves. If it is excretory in pathology, it is called as epiphora because it is because of the imbalance between the two systems, and it could be either functional or anatomic, and let's see how to differentiate between the two. Before I proceed, I'll show you this wonderful video where I'm staining the lacrimal gland with a fluorescent strip, and you can see how you can see actually the excretion of tears from the lacrimal ductule. So you can see that the tears are flowing down, how they go along the eyelid from the lateral canthus to the medial canthus. And then with each blink, because of epiphora in this patient, you can see them going down the tear trough that is on the skin, causing dermatitis. Part of them are also going into the punctum and the canaliculi. So this simple test with the help of a fluorescent strip can be done on any slit lamp. I have just recorded it with a video, that's why it looks very fancy. But coming to what causes epiphora. So punctal disorders are known to cause epiphora now in recent times more than even nasolacrimal duct disorders. So as students, we always believe that oculoplasty is just restricted to DCRs and DCTs, right? But nowadays in private practice and even in other busy oculoplastic clinics, we see that punctal pathologies, because of ocular surface disorders, secondary to ocular surface irritation, are becoming more and more common, especially in post-cataract surgery patients, drug-induced punctal pathologies, and cicatrizing disorders. Apart from that, punctal pathologies lead to a spillover into the canaliculus as well. So you can get canalicular obstructions because of punctal etiology or because of recurrent viral conjunctivitis, because of herpes zoster, because of multiple anti-glaucoma medications. Coming to the favorite of ours, that is the nasolacrimal duct pathologies, I'll keep that for later. But then lacrimal pump weakness as we age, pseudoepiphora, nasal diseases, and then aberrant nerve regeneration come down the list. Now, how do you evaluate the lacrimal system? In this case, the diagnostic is mostly clinical. You need very few equipments, you need very cheap equipments to diagnose any pathology of the lacrimal system. You don't need very expensive equipments like you do for specular microscopy. But there are certain adjunctive tests which we should know as students, which are of help when a clinical diagnosis cannot be made conclusively. These tests are needed maybe in 5 to 10% of the cases. So these tests are dacrocystogram, dacroscintigraphy, an OCT which can be used to image the punctum now, and nasal endoscopy, which nowadays is catching vogue amongst oculoplastic surgeons. Now let us go to certain case scenarios which help us understand why looking at the punctum is very important. Now this is a 40-year-old male coming with recurrent redness and watering, no discharge. But you can see this is, if you look at the date, this is June 2023 and this is 2024 recent March. So you can see in June he was quiet, and then in March you see the punctum is showing inflammation. There are a lot of follicles, congestion of the bulbar conjunctiva. But even here, if you see, there is a ring of whitish tissue around the punctum. Now this should tell you that there is some basal inflammation going on, and this is now classified as inflammatory canalicular disease or ICID. This is very commonly seen nowadays post cataract surgery, maybe because of drug induced ICID, or post dry eyes or ocular surface diseases. This responds very well to topical therapy if caught in time. If not caught in time, this can lead to canalicular stenosis and obstruction, which can be reversible. Similarly, in ladies, if lot of eye makeup is applied along the eyelids, you can see the eyelid makeup almost going into the punctum. So this certainly again leads to inflammation of the punctum and causes inflammatory canalicular and punctal disorders and punctal stenosis. So this needs to be stopped in time, and the patient needs to be started on anti-inflammatory, maybe steroids or long-term immunosuppressive drugs. Third, this is very commonly seen. This is a clear-cut case of punctal stenosis. If you look at the corresponding OCT, you can see that there is a slit-like punctum opening here if the OCT passes through this. And this can be treated, traditionally we used to do 3-snip punctoplasties, or nowadays we do punctal dilatations or Monoka intubations for these cases. If caught in time, again it has very good prognosis. Sometimes repetitive surgery is needed, but this is one of the commonest causes of epiphora. Now this was an 18-year-old female who had watering since birth. Okay, she was watering since birth in one eye. If you evert the eyelid and see, the upper punctum is almost not present, but if you go further away, you can see a small area of trans illumination if the light is focused. So this is a case of punctal membrane, or also called as idiopathic punctal membrane of the external variant. If you look at the corresponding OCT, there is a membrane here, which after you puncture it, there's no fancy surgery required here. You just need to take a punctum dilator or a 26 gauge needle, and on that membrane, you just need to make a puncture, and sometimes fluid comes out because there's a lot of fluid accumulated within the canaliculus, and these patients have very good prognosis. Now, these are all pathologies of the punctum which can also have sort of implications on the canaliculus, but sometimes in cases of functional epiphora, you might not have any of these evident pathologies. So how do you distinguish between those? Now, before going there, look at this gentleman who was 50-year-old male, had a very good cataract, uneventful cataract surgery, but complains of watering after that. Now, what was missed is the laxity of the eyelids. If you see, there is a notching or peaking of the eyelid, a hammock effect there, which sometimes, because of the speculum used during cataract surgeries, can lead to transient orbicularis weakening. So usually these patients need to be conservatively managed for 3 to 6 months and then dealt with if the watering persists. But subsequently, if you look at this same person, if he ages up to the age of 70, this goes down further, and this will lead to gross epiphora. So they certainly need some amount of surgery before going ahead or doing any other intraocular procedure. Now, how do you diagnose lid pathologies? These also can be diagnosed with very simple tests. This is the snapback test, where you pull the lower lid down and let it snap back into its original position. Now, in this lady, you can see that it has not snapped back completely. There is a mild grade of ectropion, so the snapback test is positive. If it doesn't snap back on its own, but snapbacks after a blink, then there is certain laxity, and sometimes even with blink, it doesn't snap back, so that needs ectropion correction. But even fluorescein dye instillation in these cases and asking the patient to blink right in front of you gives a huge clue, because you can see instead of the dye falling out from the medial canthus, which happens normally, here the dye is coming out of the lateral canthus. So this signifies lateral canthal tendon laxity, which needs to be corrected, and it is an identifiable cause of epiphora in age groups or where there is a lateral canthal tendon laxity. As Dr. Samrat pointed out, even floppy eyelid syndromes have this epiphora from the lateral canthus. Apart from this, there is something called as the distraction test, which is again a sign of eyelid laxity, where you pull the eyelid away, and if that eyelid can be distracted beyond 6 millimeters, then the distraction test is said to be positive and is a sure shot sign of sure shot indicator of epiphora being because of the eyelid laxity. And the lateral canthal tendon laxity test as well, because the lateral canthal tendon goes and inserts on the orbital rim. So if you can pull the lateral canthal tendon towards the lateral limbus and it comes up to that margin, that means the lateral canthal tendon is lax and you need to fix it as to treat the epiphora if the patient has any. In a younger patient, in an older patient, the lateral canthus displaces down. As we age, it goes down. Ideally, the lateral canthus should lie a millimeter or so above the medial canthus. So if we draw a line, it should be lying above. So if you see a comparative photo of a patient who is young versus to a patient who is aging beyond the age of 50, 60, the lateral canthal tendon starts descending down. So this is also a clinical indicator that the eyelids are getting lax. Floppy eyelids already Dr. Chatterjee has spoken about, but you can see the lacrimal land as well once you distract the eyelids from the globe. So that's an indicator of floppiness of the eyelids, and it's a very common cause of chronic ocular surface irritation as well as congestion. These cases are very unfortunate. Usually this lady had watering from the right eye. If you look closely, you can see a notch forming here. So she was a case of trauma who was managed in a general hospital, and this was how the suturing was done. So this is very unfortunate because nowadays most of the ophthalmic hospitals are adept at managing canalicular injuries, but a canalicular injury can also lead to unilateral epiphora. Now coming to our favorite part of epiphora, we all know, I don't need to talk about this too much, there are multiple valves and this system ends into the inferior meatus of the nose, and depending on what pathology lies, you can easily clinically identify the level of pathology and where exactly the pathology needs to be treated. So I'll go from a child to an adult. So in children, when we get epiphora, the commonest test which can be performed in the clinic, because they're not very cooperative for examination, is the fluorescein dye disappearance test, where you instill fluorescein in the cul-de-sac and wait for 5 minutes. If there is dye persisting beyond 5 minutes, then it is positive. And then certainly you need to, any child below the age of 4 or 5, you should subject them to an EUA. There is Jones test, which is not very commonly used in the clinic, but you should know about it from the exam point of view, how it is done, whether the Jones dye test 1 versus 2. Jones dye test 1 basically signifies if there is an anatomical obstruction, and if it comes negative, then you irrigate with the help of a cannula, and then you can differentiate between partial obstruction versus functional obstruction. Now, why EUA is important? Because suppose a child comes to you with watering, the commonest diagnosis you think about is an allergic conjunctivitis or a congenital nasolacrimal duct obstruction. But sometimes, as I showed previously, you can see that sometimes even children might have congenital membranes over the punctum, as seen here. So during an EUA, you can open up this membrane, put a Monoca tube, and give good relief from watering and long-term relief from watering. What do you need to evaluate children, especially while doing an EUA, is very simple instruments. You can have an endoscope, you might not have an endoscope, but usually probes are more than enough. And this is a quick short video which shows how endoscopic evaluation or probing is done in these children. So you dilate the punctum with a Nettelship's dilator. It has to be very gentle in a screw fashion. You should not apply too much force. And then I prefer a straight cannula, which according to the dimensions of the canaliculus first goes vertical, then you pull the lid towards the lateral extent, and then slide the cannula slowly inside up till you reach inside the sac, hit a hard stop, and then rotate it and rest it on the trochlea. So here I am in the sac now, I feel the hard stop. You rotate it, rest it on the trochlea, and then perform an irrigation. This is the right way to perform an irrigation. It should be very slowly done. It should be done with a 1 or 2 cc syringe. If you do it with a 5 or 10 cc syringe, you are going to get false positive results, because the more the pressure is applied by the syringe, more chances of egress from the opposite punctum. So you can see how mucus comes out. Now, probing can be done in a similar fashion. I'm not going to discuss in detail about the probing, but the same method is followed. Now, these are very common scenarios which we see in our practice, where acute dacrocystitis is mainly a clinical diagnosis, but regurgitation on pressure over the lacrimal sac is one test which is commonly performed in clinics, which gives us a clue towards diagnosis of a frank nasolacrimal duct obstruction. If you see this test positive, you don't need to do any further tests. Now, irrigation is very commonly done by all the residents. I will not show a video of the irrigation, but depending on what results come out, I've seen in medical colleges, or sometimes we do irrigation with a 26 gauge needle. We just cut it off. That is a strict no-no, because cannulas are very cheap. You get them for 2-3 rupees. You'll get them at the trade exhibition also. But these 26 gauge needles cause a lot of trauma inside the canaliculus, so should be avoided. But in a clear case, the fluid will pass down into the throat. Sometimes fluid will pass down into the throat even if the sac is inflating. So this is called as atonic sac. So this is a false positive test where, in spite of putting the fluid down and in spite of the patient complaining of epiphora, you get a clear, you don't get regurgitation and the fluid passes down the throat because of weakness of the sac muscles. In frank cases of obstruction, you will get mucus coming along with the sac from the opposite punctum. In cases of common canalicular obstruction, the fluid will come out immediately within a few seconds. As soon as you pass, there might be a little bit of pain, and these can be further differentiated by using a probe and noting the movement of the caruncle and noticing a soft stop on probing. This is a pictorial depiction of the same. Sometimes if you don't stretch the eyelid properly, you can get a false stop, soft stop because of kinking of the canaliculus. In cases where there is an encysted mucocele, where you see a mass in the lacrimal area, you can still get a block like a common canalicular block, because the mass effect kinks the common canaliculus and then you get egress from the opposite punctum itself. Canalicular obstructions, you get immediate regurgitation from the same punctum from where you're doing syringing, and sometimes false positives can be seen in cases of dacroliths, and you can get variable syringing outcomes at different occasions. So this all I have discussed. I'd like to end this talk by saying that if at all you want to use an adjunctive test, now cone beam CT scan, which is basically a dental scan where the patient is sitting in a physiological position, you instill dye in the cul-de-sac just like you instill eye drops, and then you notice you acquire acquisition images all around the patient, and you get very beautiful images of the canalicular as well as the nasolacrimal system. You can see even 3D reconstructed images showing a diverticulum as seen here. This is an outpouching from the lacrimal sac. This is a diverticulum which can be then 3D reconstructed and helps us in management surgically. But the gold standard, if you want to know about the physiology as well as anatomy, now is digital subtraction dacryography. So this is basically just like how angiography is done. With the help of an angiocath cannula, you go in and instill the dye and acquire fluoroscopic images, just like how a C-arm is used for orthopedic surgeons. And then you get very beautiful images as you see here. This is the whole lacrimal system delineated. Here you see a stenosis of the lacrimal system, so some part of the dye has gone back. Here you see outpouching of the lacrimal system. Here there is a dacrylith which is obstructing this, and here you can see a stenosis right at the mid-level of the sac. So there are different management varying depending on where the blockage lies, what the blockage cause is, and whether the eyelids or the ocular surface is involved. This is just a small empiric diagram which shows the management. And to summarize, most important part in evaluating the lacrimal system still remains clinical examination and history taking. You don't need too many equipments. Maybe in 5% of the cases you might need the adjunctive therapies, adjunctive diagnostic modalities which I spoke about. In a child with epiphora, if you're not sure and if you're on the borderline, always perform an examination under anesthesia, because you're looking at long-term prospects. Digital subtraction dacryography is the gold standard if you are not sure about the diagnosis or if it is a complicated case. And always examine the adnexa before you directly jump on to perform lacrimal syringing or irrigation. Thank you.
I think we still have some time for questions. We have around 8 minutes. So anybody would like to, it's now you've been here in this hall for nearly an hour, so I think the initial inhibitions should go off. Any questions to any, yeah, please come to the mic so that everyone can hear. And before she comes, I think it's a very excellent talk that Dr. Adit has given. So anytime a patient comes with watering, don't jump and do a syringing, because after that when you find it patent, then you don't know what you're going to do with it. Most of the allergic, and then label it as allergic conjunctivitis till next evaluation, either by you or by somebody else. Please.
Sir, in case of regurgitation of clear fluid from the opposite punctum, what would be the best modality for management in terms of surgery or tubes?
So as I mentioned in my talk, if there is clear regurgitation of fluid, then the block is either
Common
at the
canaliculus.
common canaliculus or it could be inferiorly as well, in the sac as well. But since sometimes sac block will not always have mucoid regurgitation. Okay, the sac can sometimes be small,
Right.
it could be fibrotic, where there is no space for mucus to stay. So if
Okay.
you see older patients, like if you syringe a patient beyond the age of 60, they usually have chronic fibrotic sacs. So they also will have clear regurgitation from the opposite punctum. So you need to differentiate between the two. But in any case, if you have a block at the common canaliculus, there are two schools of thoughts. One is, since you have a block at the common canaliculus, you don't know whether the nasolacrimal system is patent or
Patent or
no.
not.
If it is not patent, then obviously you have to go ahead and do a DCR.
External,
But during a DCR, you also have to do a canalicular trephination. So there are different types of trephines available. The commonest one used is Sisler's trephine,
All right.
which is basically like a tube boring machine which is used for metro construction. You know,
Okay.
whatever. So you put that inside the, you have to dilate the punctum and the canaliculus well, and that trephine is advanced further, and then it is bored. If it is a common canalicular block, it is very easy because the tissue is hardly 1 millimeter.
All right.
And you get very good outcomes. So if it is just a common canalicular block, you can, there are surgeons who go endoscopically as well,
Right.
and then intubate and then come out through the inferior meatus rather than doing a DCR. So some people, if you are very familiar with using the trephine, you can just do trephination. Following trephination, you can do syringing. If the syringing is patent, then you can just do intubation, which is done in a child where you come out through the inferior meatus, or you can put a monocar tube which doesn't need any secure connection in the nose.
So trephination need not necessarily be followed by a tube being placed. We can just leave it.
No,
after.
ideally if
have
you are,
to.
yeah, because the canaliculus is basically mucosa, right?
Right.
If there are two raw surfaces, it's going to stop, close
Exactly.
again.
So we have to leave
even if you put a mini monocar tube, which is basically a monocanalicular intubation, that is more than enough, because then you don't even need to retrieve the stent down into the nose. So that's the easiest way out. But if you're doing a DCR, then a bicanalicular intubation is preferred.
So ideally, after we get regurgitation from the upper punctum, clear fluid, we are supposed to further evaluate with Jones test to see whether the block is
So
there.
the best test to do would be a probing test. So
Probing
if you put a probe, metallic probe, if you have a soft stop and
Right.
the caruncle moves, then it's a common canalicular block.
Yes.
But if you can go right into the sac and feel the bone, then it's a nasolacrimal or a sacral block. So the management will, you don't need to do a Jones test, just a
No,
simple.
that will tell us about the common canalicular block.
Correct.
But what if we don't know if there's a block beyond that? So for that.
So
we
that's what. So if you do a soft, yeah. So you cannot do a Jones test because Jones
See,
test
exactly.
is
So
not.
how do we then
You cannot do anything. You just have to intraoperatively. You have to.
check for the
Yes.
free flow and then
Yes.
plan accordingly?
Yes.
Okay. So thank you.
Can you tell them what not to do during syringing? What all things they should avoid?
So the first thing that they should avoid is using a 26 gauge needle, because that is the most traumatic thing which can happen to your canaliculus. Even though you're cutting the tip, the bore which remains is very sharp. So that can cause false passage first of all, which is incurable. Once a false passage happens in a canaliculus, it's almost you cannot treat it. Second, you have to make the patient very comfortable. In olden days, I remember even in my internship days, we used to make the patient lie down and do the syringing. Ideally, it should be done in the physiological position. So nowadays, everyone has chair units. So you can just make the patient sit, make the head rest behind, and wait at least for 2 minutes after applying topical anesthesia, and then do the syringing. Ideally, use a 1 cc syringe and a 26 gauge disposable lacrimal cannula or a metallic cannula. A straight cannula is always better than the bent tip one, from my personal experience, because then it's easier in the canaliculus. You don't have to navigate the curve of the needle, and the irrigation pressure should be very slow. So you should not force upon anything. It should be very, very slow, so that you don't get any false positive or false negative results.
I think all are waiting for
Any
the next
other?
session.
There's still how many minutes? There's still 2 minutes. Anybody would like to follow up on that question? Maybe we can-
One question I had, how means, do you think that floppy eyelid syndrome now we are seeing more and more commonly in clinical practice, and if at all, how do you treat the surface? Because from the eyelid point of view, there are not many answers to treat floppy eyelid syndrome.
We are seeing it more probably because we are becoming aware and we are diagnosing it more. So I think that's the one. But there's hardly any solution much for that.
Thing is that whenever we see the floppy iris, sir, we ask the patient the sleep apnea is there. Most of the time the sleep apnea is there,
Yeah.
and the exposure time is there. Then you have to be just address the systemic disorder, and then definitely it will be subsides because much more you can do for these things.
Yeah.
One thing I just request the Shamrat sir, just can you highlight them whenever for the PG actually. Whenever we are suspecting the OSD, what are the do's and don't before doing jump for the cataract surgery?
You
When
should,
is
treat,
suspected?
you should treat blepharitis, you should treat dry eye and then do cataract surgery. Bottom line. MGD, you can do cataract surgery and give them artificial tears. Don't give NSAIDs following cataract surgery in people with OSD.
I think most, and sometimes if it is needed, suspect the patient has some autoimmune disorder, never hesitate to take the clearance from the immunologist, and it should be done in the proper immunosuppression conditions, especially oral steroid, and if needed, the immunosuppression. Specifically, when dealing with the OCP patient, it should be the immunosuppression should be there. Otherwise, the patient landed abdomen, and never hesitate to put a suture in the shade of your egos, and whenever suspect the cornea is very thin, then put a suture at the wound. If you do the clear cornea too also.
And also punctal occlusion. That's very distinct.
That's and this very simple thing make the change the lifestyle of the patient.